Well, welcome everybody to Optometric Education Consultants National Webinar Series, Tuesday night edition. We're going to be talking about the 7 habits of highly effective anterior uveitis management. And we're very fortunate to have a leader in the field and a very close and personal friend, Dr. Paul Karpecki, who received his OD degree from Indiana University and completed a fellowship in medical corning in Kansas City in affiliation with Pennsylvania College of Optometry. He currently serves as Director of Core and External Disease for the Kentucky Eye Institute in Lexington, Kentucky, running the largest advanced referral-only ocular surface disease clinic in the U.S. He's also an associate professor at the Kentucky College of Optometry at the University of Pikeville in Pikeville, Kentucky. In 2017 through 19, he completed a 2-year preceptorship in advanced retinal disease at Retina Associates of Kentucky, and has a special interest in the diagnosis and management of uveitis. He's chief medical editor for Review of Optometry, the most wide-read publication we have in the field. He chairs the New Technology and Treatment Conferences and serves on the board of the charitable organization Optometry Giving Site. So with us, please give a warm welcome to our esteemed presenter for this evening, Dr. Paul Karpecki. Paul, take it away.
Thank you, Joe. Thank you, Greg. What a wonderful introduction. And thank you for what you provide for our profession, these forums of education, how always so professional, well done. And it is true, I've been lucky to be friends with Joe and Greg for a long time. It's one of the great things about our profession. We share so much collegiality amongst the profession. It's really unseen by most other medical professions. It's a real blessing to me, and I'm honored to get to present, and thank you for the invitation. Most importantly, thank you to all those who are spending their evening learning about uveitis. I know you're busy, lots of things you could be doing. It's a voting night, so really says a lot about you, and I'm grateful for your attendance. So this really is meant to be kind of a relaxing kind of presentation, believe it or not. It's just taking stuff that you probably know. And I love that, 75% of people were pretty comfortable with it, at least if you look at the numbers, 12% very comfortable with it. And it's really designed for that group. But I think you'll find no matter what level of uveitis management, really talking anterior uveitis, which makes it a lot easier, somewhat easier, that you're going to know a lot of these things. This may be just the first time that's all compiled in kind of an easy 7-step process, so to speak, of how to manage it. So there's my disclosures, companies that I've done research with, advisory boards, speakers bureau, anything in the last 3 or 4 years. Many of those are no longer companies I work with, but nevertheless, I got to update at some point, but it is pretty current for 3 years and up, and shouldn't apply to anything we're doing today. Case history, let's just start with this. Always makes sense to kind of begin with it. And hey, when we get to the polling questions, are you going to insert these as we go along? Greg, Joe, how does that work real quickly from a logistics standpoint?
I have them uploaded. If you have a slide, I'll launch them when you get there. So
fantastic. I don't know. I think I do have it. I'm not positive, but that'll work out great. I may have not grabbed the same presentation, but you can interrupt me when it's time to launch. So let's hit this case history. And I think it's just a good way to begin because it sets us in the stage of, hey, what if this patient's in my office tomorrow morning? Where do they fit in? How do I manage them? What am I looking for? So we'll start with a 68-year-old lady, assuming this patient does come into your office tomorrow, complaining of photophobia and blurred vision. So far, nothing too abnormal. That could be dry eye. That could be eye misalignment, trigeminal issues. Could be certainly uveitis, but there's a lot of things that fit into that as well. But she's got this headache over her right eye for 2 days. Again, not too atypical, but does give us a little hint into what's going on. Classic sign of anterior uveitis. You don't always get this, but if you do see this, it usually is a nice indication that that's what's going on. And of course, you've probably guessed what the sign is. But if you look, there's a difference in the injection depending on where you're observing the conjunctiva. If you look towards the limbus, circumlimbal area, you see there's a greater amount of flush or injection. So again, ciliary flush, this is sometimes called circumlimbal flush, or a greater amount. And of course, that's where the uvea lies, right below that area, as we're going towards the choroid and the iris at the limbus, that kind of category. So it makes sense you're going to get more injection there. again, you don't need the sign to identify the fact that there's cell flare. In fact, many times you're going to see cell flare without this sign. But if you do, it's kind of a nice little hint of what's going on. And she had this. There's no question it's present. Now, this was a little atypical. As I looked at her cornea, I see this pseudodendritic appearance. It looks a little linear, but also looks very superficial. So it's one of those ones where you look on the eye and you think, I'm not really sure what that thing is. It looks kind of unique. At least that's what I thought. It's no ulceration, so I'll give you that hint. You know, a true simplex kind of condition would be ulcerated or terminal end bulbs. This is more pseudo, kind of on the surface. If you look at it individually, there might be a better picture to kind of gaze at it because the patient was somewhat photophobic and moving around a lot. You can tell there's no pooling, really. I mean, it's hard to tell, actually. As you look at some of those branches, it might even look like there's some pooling there, but I'll give you the word that there isn't any. There's no breakdown in the epithelium, so to speak. It almost sits on the surface. I'll give you another example in a moment that kind of helps isolate it a little better. And then this is not the same patient, but I wanted to give you an example of a patient where, you know, you can get significant swelling of the cornea. She had a milder form of it. If we go backwards to where she's at there, she can see some haze in the center. You can see a little bit of pigment on the lens. Can you guys notice that? That's there, kind of an interesting little finding, even though we're looking at ciliary flush there. So I use this example here to kind of emphasize just how swollen a patient with this condition can get. This is not our patient, but is a really good example of just the level of edema and inflammation that occurs. In fact, I'll tell you, this patient's pressure, if you were to guess what it is, IOP, I bet it'd be hard to tell because normally if you have an anterior uveitis, the IOP goes down. The ciliary body somewhat shuts down from inflammation. It's not producing aqueous, but this patient's pressure was 56. So we'll talk more about that and how it all applies and where it fits into. So what do you think in the diagnosis is? What would you ask the patient? What would you look at? And really, there were no other findings. I mean, there wasn't anything that I could see outside of the eye. She looked pretty normal. I mean, she was photophobic. She had that headache over that same right eye. There was some corneal edema. Her vision was about 20/40.
Hey, Paul, I have a question for you.
Please, this would be a perfect time.
In the era of like, testing for cornea sensitivity, would cornea sensitivity help us out here at all?
Yeah, it would. It's a great suggestion. It helps us out in a couple ways. Number one, this condition is very known to become neurotrophic over time. In fact, I had 2 patients today with this who now are at least 4 or 5 months post the level of inflammation with this, who are neurotrophic and have a lot of central staining I'm trying to get rid of. One with a small persistent epithelial defect, the other one with just grade 4 staining right in the center. And both were completely neurotrophic and both had this. So there's no question it is. But this early in the disease, the reason why that's so important, Greg, and I know you know the answer, but is it might help to differentiate a herpes simplex case, which tends to be neurotrophic early on, versus something perhaps like her varicella, that could actually be less of that early on and becomes neurotrophic later in the disease. And because we're trying to differentiate a dendrite versus a pseudodendrite, it's a very good suggestion.
And Paul, was there any iris atrophy? Not
in this case. That's a great question too. And I'll tell you why. If you go back to this picture here where you're seeing, synechia, or at least some history of synechia, you've got pigment on the anterior surface of the lens. That tells me there's some chronicity perhaps to this, or the fact that maybe it was just there and it's starting to break a little bit is a possibility. It could be acute, but usually not. And atrophy of the iris is one of the hallmark signs of herpes simplex. And there's no atrophy and there's no neurotrophic finds here. But Joe, that's a brilliant comment. I get patients coming in on a regular basis who've had like their 4th bout of uveitis, anterior uveitis, and they're wondering, why does this keep coming back? And the doctors that have been seeing them did all the right things. They cycloplegic, they put the patient on heavy steroids, they tapered nice and slow to allow it to not rebound, and they're wondering, why is this rebounding? And the patient comes in, and I notice iris atrophy to go along with the anterior uveitis. I know Joe knows the answer, so I asked this great question, but that is a hallmark sign of HSV uveitis, herpes simplex. And what makes that so cool, Joe, is that that's the patient where you go ahead and add Valtrex to the regimen. Same thing on steroids, same thing on cycloplegia. You're still treating uveitis, but you add in oral Valtrex, and now they go like a year or two with it coming back. It's fascinating if you pick up on that insight, that atrophy of the iris in a chronic uveitis case, that's HSV, and adding in oral Valtrex, you'll have even way better results than just using your steroid and your cycloplegic agent. Brilliant. But no atrophy and no neurotrophic effects at this stage. So that kind of
Paul, somebody asked in the question, what about the pupil reaction, and what is the normal dosing that you like to do for this condition in terms of Valtrex? Two separate questions.
Yeah, this is a great way to do a webinar. So much better than like listening to someone talk. I love these kind of questions. So first of all, pupil's a little sluggish, kind of a little bit. It's fairly myotic. It is smaller than on the other side than it is, but not a lot of good movement of it either. So it could be a little of the edema, but it was myotic compared to the other eye. Good question. And then dosing we'll get into steroid dosing, but for Valtrex, what I typically do on these patients is 500 milligrams 3 times a day for about 2 weeks. If I'm treating an uveitis that I know or I think is HSV because I'm seeing atrophy, or to Greg's point, I'm noticing there's neurotrophic effects in a younger patient, likely HSV. I will go with 500 milligrams valcyclovir TID 2 weeks. This is great. I love the questions. All right. So, well, I delved into her headache a little more. So, okay, tell me a little more about this headache you've had for 2 days. And that's finally when she gave the answer. She said, it's very specific. It's right in this region. I can't even brush my hair, comb my hair. I can't even brush her hair, I think she said, in this area. It really was right over this side. So I thought, oh, you've just helped me. There's probably only 2 things I'd be worried about in this patient. One that has a high association with anterior uveitis, and one that's more serious for losing vision that probably doesn't have an anterior chamber reaction. And of course, the second one's trigeminal is you're looking at your case temporal arteritis. She didn't really have anything that tied into temporal. While she had some headache here, she didn't have any tenderness of her temporal artery. She didn't have any malaise. She hasn't been ill. She hasn't been losing weight. She hasn't had a TIA. Nothing pointed to that. So the other one, as you probably guessed, that respects the midline, I started looking for lesions. There was probably some lesions in the scalp that are on this half. There were none. I thought, well, that's crazy. I come to find out, and the first time I ever did this in a patient who didn't have lesions, who had herpes zoster ophthalmicus, I had no idea that 1 out of 5 cases of herpes zoster actually present in the eye before they present on the dermatome. And she happened to be one of those patients, no lesion. So I figured this is herpes zoster because of that tenderness to this part of the midline, the anterior uveitis, the pseudodendrites. And I put her now, in this case, I'm dealing with zoster. So you asked about simplex atrophy earlier. That was the 500 milligrams of valcyclovir TID for 2 weeks. For herpes zoster ophthalmicus, which is kind of what we end up having here. For HCO varicella, you double the dose. It's 1,000 milligrams, still 3 times a day. And I typically do 10 days in a patient who's around 68, 70. I think that there's a little more shedding in older patients of the virus, more than 7 days. So 10 is perfect. You don't really need 14, but you could do that as well. So 10 days seems to work well on that. So if we go back over the history of this patient, we were right with herpes zoster, and 1 out of 5 cases will present in the eye. It's a common condition. About 1 million Americans develop it each year. Now, what's baffling about this is that the numbers actually have slowly increased in spite of having a vaccine for herpes zoster. And why do you think that is? Why would we get more of this condition when a vaccine has actually been shown to decrease the incidence by about 50%, especially the latest versions, Shingrix and that group? Couple interesting reasons. Number one, not that many people get the vaccine, and it's unfortunate because it is really an effective vaccine. This is one that makes sense to do. I've seen too many patients with severe levels of this that it fits in. Number two, they came out with a vaccine for herpes zoster and about the same time a vaccine for chicken pox. And of course, they're the same varicella. So theory is that 15, 20 years ago, grandparents would be having, hanging out with their grandchildren, being exposed to varicella, building up antibodies, and not likely to see the manifestation of dorsal effects. And today, a little bit different, because without that, there's no exposure. You really almost have to have the vaccine to get there. But ophthalmicus can be as much as 1 in 5 or 1 in 4 cases. Over 50% of patients have long-term damage to the eye. And I'm going to hit that in a moment, what that means.
Paul, what I had recently read was it seems to be diminishing in the elderly, but popping up in the younger population,
It makes
like
even,
under 60.
That's really interesting, Joe. And I think you're spot on. And it makes sense because as parents, if you had a child with chickenpox, you were getting a little bit of antibody buildup, because you'd already been exposed yourself typically. And now that doesn't happen. So parents today, younger age, don't have that antibody buildup to the same extent that they would have had many years ago. And, certainly stress plays a role as a trigger. Maybe that's a factor. But, I have to say clinically, you're spot on. I feel like I see zoster showing up in my clinic in a lot younger patient population than I recall, 30s, 40s. And a lot of that very commonly. And, it's funny because back when, you and I were early on lecturing and doing a lot in the world of cornea and anterior segment, if we had a patient who was 30 who developed herpes zoster ophthalmicus, we were ruling out conditions of immunology such as HIV or other immunocompromised conditions. Today, we were like, that'd be silly to do. That's just a patient who we're seeing it in younger patients all the time. Spot on. Hutchinson sign, I think you all know this one. Lesion on the tip of the nose. It's worth looking. I mean, this patient, of course, had no lesions. What's interesting about this patient is I went ahead and put her on 1,000 milligrams of valcyclovir 3 times a day for 10 days. I figured that's what's going on. I started with heavy steroids. We're going to get into therapeutics for uveitis in one of the 7 steps. Don't worry, we'll get right into that. I had her come back the next day simply because I wasn't really sure. Her pressure was 56, or no, her pressure was 56, but it was like 40. And so I had her on some glaucoma meds, not prostaglandin analogs, but I think I had a Combigan or combination agent, I should say. And so I kind of got her to where her pressure was okay, and I want to see her the next day. And the next day, she had lesions in her scalp, on her forehead, all there. It's kind of interesting. So she saw me and she got worse the next day. I always feels good as a doctor when they come back. And now they do have that. But I warned her. I said, there's a good chance you're going to get some lesions showing up because I'm catching you before it's presented there. And you've already got all the symptoms and everything matching the midline and over. And sure enough, that's what happened. And she did have a lesion on the tip of her nose. I wish I had taken a full picture of that. But this is something you'll look for in the fact that if you have the nasociliary branch involved, it's pretty hard to have the nasal without the ciliary. So, in most cases, you're going to have ophthalmic involvement. So it's worth looking at. I'm going to guess 98% of the time, if you have a lesion, a Hutchinson sign on the tip of the nose, you probably have eye involvement. But the interesting thing is, what percentage do you think, and I'll ask Joe and Greg this, because there is no answer I've ever seen, but what percentage do you think of patients who don't have a Hutchinson sign still can have zoster ophthalmicus presentation?
Yes. I think it's pretty high. And when you say 98% with the tip of the nose, those rare people, they may have a lesion on the tip of the nose and they don't have, you don't have eye signs. Well, they're uncomfortable or they're photophobic. You may not see anything, but, they do have internal inflammation going on. So there may not be any signs. The symptoms are enough there. But I see a pretty good amount with eye signs without Hutchinson sign.
My experience as well. I think that the large majority of patients don't have Hutchinson sign, but have ocular involvement. So having it means it's in there. Not having his Hutchinson sign means you still got to look to see if it's in there, because it could well be, just as Joe said.
And I think we just need to be careful. I think we're looking for cornea. I think we're looking for dendrites, but I think ocular involvement could just be a little bit of redness, a little bit of injection that's out there. So I think we're always worried about that leading cause of cornea vision loss that can occur with these. But, I think ocular involvement, more than just eyelids, globe involvement, could just be a little bit of discomfort, and a little bit of redness.
Agreed. Well said. Great insights. Is this one of those polling questions?
Yeah, let's see what happens here, other than me shutting down my computer here. Let's throw this out. Thanks, Paul.
You bet.
And Paul, interestingly, and Greg brings this up a lot, and we both talk about this. We get a lot of these patients who are accurately diagnosed and accurately treated by a primary care physician, nurse practitioner, physician assistant, and they send them to us anyway because they can't determine if there is ocular involvement or not.
That's right. That's right. Exactly. Hey, I did put it in the wrong place on you, Greg. Can you
Sorry.
hold up on poll one? Let me go to the question, or is it too late once it's up here?
No, I can relaunch it. Let me hit it back and I'll relaunch it. Yeah.
Hey, look for that in the near future, everybody. We're going to hit that in a moment. See, I had some questions I put in. These are the right polling questions that I sent. You got them. They're perfect. And I do want these to be in there later, but I can't put them out there right now if I'm not covering it for you yet. You probably get the right answer, but let's put it in the right spot. So what we had Hutchinson sign already. So my question I did throw out was just, okay, what are the typical findings? So we hit some of these already, and erythema, pustules on the dermatome respecting the midline, the red eye that Greg described and Joe described, the conjunctivitis, all but it could go all the way to scleritis. Pseudodendrites, that's what those were. A true dendrite would have terminal end bulbs and probably would have some ulceration in some cases. Neurotrophic keratitis, that's why it was so good insight, I think by Greg to talk about, hey, did you check, would it help to check for corneal sensitivity, get a little dental floss or a cotton wisp and see if that's present. And although that is a great test in this case, because you're trying to rule out simplex, the NK from herpes zoster ophthalmicus is typically going to be later, like could be 2-3 weeks later, it could be 2-3 months later, even 6 months later, but it tends to be after the acute inflammatory stage. I still think this is the most inflammatory condition that typically shows up in my office. In terms of all the conditions I see, there's just so much inflammation. These patients go on to everything from lipid keratopathy to retractable uveitis. So it's really, that's the answer. It's going to be in the most common finding. But glaucoma can occur with herpes zoster patients. We're going to talk about that. Vascular occlusions can occur. That sounds kind of weird. We'll get into that. And even you can get a nerve palsy, Ramsay-Hunt syndrome, where it somehow affects the nerve function, and you can get ptosis or other issues, eye movement, diplopia as well with any virus. So normally you would have this to go along with it. You'd get some sort of lesions. And in fact, the patient, the image to the right, is very similar to what the patient looked like the next day. She definitely didn't have that present the day I saw her, but definitely did the next day. The picture on the left, of course, much more advanced form, but just want to give you a few good examples. So here's another example of pseudodendrites. You notice they're almost wispy. They look like they're almost on the surface. There's no ulceration. It's not darker terminal end bulb staining or anything like that as well.
Paul, would you classify those more as kind of humping, more additive rather than subtracting?
That's a great way of putting it, Greg. 100% right. And in fact, that might be the best definition for differentiating the two. This is going to be almost on the surface. It almost seems like to me, it's additive is a great description. An ulcer from HSV or a dendrite is going to actually be subtractive. You're going to get into tissue. You're going to get pooling and the terminal end bulbs. Beautiful way of describing it. If you look at the anterior chamber here, you're seeing some keratotic precipitates, but you're also seeing cell and flare. It's hard to get a good picture of cell and flare for presentations, but somehow zoster patients come through for me on this. They just seem to have more inflammation as a whole, and it shows up.
It's like the Holy Grail, Paul. It's just hard to get a picture.
It is. It is. So wait for your next zoster. That's a few times you get a really good one. You just don't see, VKH and other things like that enough. They say those are easy to get pictures of too. I just don't see enough of those. Iridocyclitis and HCO. It's the most common and overlooked complication of herpes zoster ophthalmicus is iridocyclitis. This is actually done in a major center where they Thien, Hall, and Stallwell paper. It's a number of years old now. It's almost 20 years old. But I remember reading it when it was first published and thought it's fascinating, where they looked at a group of doctors who had looked at these patients. They were ophthalmologists in this study, and they missed the uveitis something like 55-60% of the cases that walked in. It wasn't something they even thought of as a common complication of zoster, and yet it is the most common. In fact, it's the main thing you're looking for when you're thinking of herpes zoster. If a patient comes in with lesions on half of their scalp or lesions on the nose, lesions anywhere up here, the most important thing to be looking for is that anterior uveitis, because it is the number one finding. 43% of all cases have it. And this is really weird. Normally, when you have a uveitis, you have, we talked about this, inflammation to the ciliary body. Ciliary body produces aqueous. What do pressures do? They go down. This is one of the few that our pressures go up. And that's one of the fun things about, I think you get to be more of a detective when you're managing uveitis than almost any other disease, at least that I see a lot of, because I'm trying to sort out what is this cause. Joe had the great example early of the iris atrophy. Well, that's HSV. You have chronic uveitis with iris atrophy. That's a case of HSV, especially a sectoral region. You add in the valcyclovir, and wow, now all of a sudden I got a wonderful response. So that's the kind of detective work. There's only like 3 forms of iridocyclitis or iritis where the pressures go up. All the other times the IOP goes down because the ciliary body's swollen. And that's why you often see most of your iritis patients have like a pressure in the one eye of 18, the other one 14, where the uveitis is with the myotic pupil. So in this case, it's going up. Just so happens the other 2 are herpes simplex and Posner-Schlossman syndrome. And there's some new research that's come out on Posner-Schlossman syndrome where they took titers out of the anterior chamber. And guess what they isolated? Herpes simplex virus. So it could best be all the herpetic family where you see an IOP that goes up. So if you've got a pressure in the eye that has uveitis that's elevated, you're thinking of simplex, you're thinking of zoster, and Posner-Schlossman, which could actually be simplex as well. And there's that study that looked at the most overlooked and most common complications, you guys. What's really interesting out of that same study is that they followed these patients who had the uveitis. So you just take those with the significant inflammation and you decide to follow them for a decade. 56% of them went on to develop glaucoma. I'm so glad I got Joe and Greg here, because while I like managing glaucoma, it's one of the things I have fun with. You're not going to see me lecturing on glaucoma. It's not, I don't have that knowledge, but Joe, Greg do. So why would this happen? How would half the people who get uveitis after HCO develop I guess, a unilateral glaucoma, according to this study? What's the mechanism?
With the pressure rise is multifactorial. You're right. You've got prostaglandins being released. It's going to lower intraocular pressure. You have secretory hypotony. It's going to lower intraocular pressure in most cases. A lot of times the inflammation is in the trabecular wall. That can raise pressure. You can get blockage of the meshwork by inflammatory cells. That goes up. Flare, it will get, if you get persistent flare, which is very, very bad for an eye, you're going to have like a motor oiling of the aqueous. It can't get out. Steroid treatment itself, it can allow it to go up. So there are a number of mechanisms that happen to raise the pressure, but ultimately you can have a trabecular dysfunction that it becomes permanent.
That's a great answer. That's the best answer I've ever heard. I love it.
The other 2 cents that I'll add is that, we've learned a lot about things being immunoprivileged, right? So like our gut is immunoprivileged. I can go to Mexico, eat a food that I've never eaten before, and I don't go into anaphylactic shock from my mouth to whenever I excrete this product. That's called immunoprivilege. Our eye is immunoprivileged inside the eye. And that's, in a sense, how some of the, the choroidal melanomas, when they metastasize, they kind of take on that immunoprivilege, and that's how they can move through the body. But you're broken down at immunoprivilege, and now you've got a dysfunctional immune system, which now starts monkeying with the pressure going up, and then it's just hard to control. So
cool.
That's just my 2 cents. So.
Love it. Love it. Great insights from 2 people who really know their stuff there. 7 rules of highly effective iritis management. So if I had to take what probably everybody on this call knows, but put it in order, this is the way I would look at it. This is a good guideline, so to speak, or 7 little guidelines that'll really protect you and the patient, and I believe allow you to manage this condition at such a high level that you could consider yourself, if you do a lot of this, as a uveitis expert. And I'm saying that not flippantly. I got some of these things from true uveitis specialists. I worked with 2 in my career that were extremely well known, that spent their whole life just managing mainly anterior uveitis, more so even than posterior, because they weren't retina specialists. They were uveitis. They did a fair amount of intermediate. One was Bill Godfrey when I was in Kansas City, and then another was up Cincinnati Eye while they were there too, where I practiced about 5.5 years. So some of the ideas came from them. Some are my own. But I was fascinated by stuff I learned. And some, they didn't even know the reason why they were doing it, but it was spot on. I'll explain those too. So first rule, and I'll go through each one of these, but first rule is to rule out infectious keratitis. That's just hey, let's make sure that we're not dealing with a fungal keratitis or a herpes simplex virus before we start putting these patients on steroids. So we'll go through that. Check pressures, couple good reasons there. You don't want a pressure that's 56 and you have complications like this one example I gave you earlier, herpes zoster. And you also don't want, it helps you make the diagnosis. You, back to that same case, I know I've hit it to death here, but the one Joe described, you have atrophy of the iris that's sectoral and an elevated pressure in that same eye with uveitis. That's herpes simplex virus. So it makes it really easy to make your differential. Number 3, you got to rule out a previous ocular surgery. We'll talk about what that means, and I think you'd know. Need to know when to get a systemic workup. You don't want this thing to keep coming back so many times because we miss something systemic that's there. Treat aggressively. I remember many, many years ago listening to Jimmy Bartlett. He used to talk a lecture on this one time. I was with him, and he used the word treat. You got to treat boldly. I love that word too. Bold is good. So everyone for years has always had this as one of the rules. Treat beyond cell and flare. I'm not just talking about tapering. I'll get into that. But this is the one where one of the uveitis specialists knew this one. Like, I remember he would send his patients over to me because he was the only specialist in the center I worked in Kansas City that didn't have an OD partner. He just was too specialized. So I was in cornea, so I had an MD partner. John Gelvin was the glaucoma OD with his surgical partner. In retina, we had Brett King. So everybody had their own kind of together there. One did all the medical. He didn't. So he would send me his, and he'd send them in, and I'd look in the anterior chamber, and the patient had been on steroids for 3 months, and it was down to once a day. And I would look carefully because I didn't want to mess up for the specialist. And I saw no cell and flare, and I stopped the steroid. And I get calls me up a week later, calls me over. He didn't call me up, calls me over, says, Paul, why'd you stop the steroid? So, well, there was no cell and flare. He goes, well, there is now. I said, what do you mean? He goes, I'll come back. I said, well, the patient had been once a day for like 3 weeks. He goes, well, yeah, once there's no more cell and flare, you have to wait another 5 days. I'm like, why? He goes, I don't know. It's just what we do. I found out later why you have to do it. And he was right. It's a really cool little guideline. And then always look at the back of the eye, even on that first exam. And I'll tell you why that's important, where it fits into. So let's go with rule number 1. We're going to rule out a keratouveitis. We're going to say, okay, how do we, when should we be really cautious with steroids? I'm going to give you the most extreme example I've ever seen, which is not typical. It's always awful when lecturers come out with something that's not normally going to be shown, but I think it emphasized a lot of things. One, patient had this small infiltrate within, like, woke up that morning in 10 out of 10 pain. Actually, he said 11 out of 10 pain. 360 degrees of injection. He slept in his contact lens. He probably slept in his contact lens a few times. He might have been there for a few days. He had 20/40 vision. Looking through, if you look at the beam there, see all that haze? He slept in his contact lens. Could have been from that, or it could have been from that infiltrate. I'm expecting he's going to have this terrible, huge Pseudomonas ulcer. He couldn't even get to the office. He had to have someone get him in there. He's got 11 out of 10 pain, 360 degrees of discharge. Look at the 360 degrees of injection. Look at the discharge in that fluorescein film down there. You see how thick the tears look and murky. There's a lot of discharge in there. Extremely photophobic. 20/40, 4 lines of lost vision. And I see this little thing. I'm thinking, I thought it was going to be a lot worse than this. I look in his anterior chamber, though. He's got grade 3 Selin flare. So non-compliant, contact lens wearer, slept in his lens, saw him within an hour of waking up because he wanted to get seen before he could go to work. Turns out this was a Pseudomonas ulcer caught extremely early. And had I put him on a steroid, probably wouldn't have done as well. So you got to be careful when there's an anterior chamber reaction when you have corneal involvement. And again, that's a pretty rare presentation. This is a little more of what I would have expected, this huge Pseudomonas ulcer in a patient. And it could be any pathogen. These just both happen to be Pseudomonas with a lot of fibrin, hypopion, terrible looking things going on. And the point to this is both of these have significant anterior chamber reaction. Both are infectious. Both don't allow you to use a steroid. That's pretty much the rule. And that's why it's so important to catch a keratouveitis early, like a true infectious cause for the anterior chamber reaction, because your rules of treating with steroid and cycloplegia go away. Now you can still cycloplegia, but the steroid's gone.
Hey, Paul, we just got a real quick question that came in. It just said contact lens wear.
Yes, very good point. Not only contact lens wearer, probably a very non-compliant contact lens wearer. Just talking to him, I don't know how many nights he's probably spent in his contact lens. He certainly said he was honest. You know, I said, "Do you sleep in your lens?" He goes, "Oh yeah, I fell asleep in him last night. Woke up in this extreme pain and loss of vision." And so a corneal lesion, let me give you another example. Here's a good corneal lesion. Hey, there's I love Greg's terminology.
Subtraction.
This is subtraction. Perfect example. There's a loss of tissue. You got ulceration. You got these really cool terminal end bulbs lighting up. That's a lot different than that additive pseudodendrite that we looked at. So you've got obviously herpes simplex. This patient, I'll tell you, had a significant anterior chamber reaction as well. So how many on the call would say, oh, they've got an anterior chamber reaction? That's a uveitis. Let's treat it with steroids. Of course not. It'd be a contraindication. So my reason I'm being a little facetious, but the cool thing is if you have keratouveitis, an infectious cause for the anterior chamber reaction, just treating the infection and the anterior chamber reaction will go away. So it's one of the times when the rules don't apply because there's a cause. Here's a gentleman who was out working in the field. He's a farmer, and he happened to scratch his eye 10 days earlier. That seems like a long time. On a corn husk, I don't know, some plant. I'm assuming a corn husk, something like that. And he presents with this nice fluffy lesion. Often these are brownish looking, but it just depends on what you're dealing with. Fluffy lesion. I had him look up and you see the hypopion on the right side and some more lesions. So point being, that's a fungal keratitis. Once again, there's enough of an anterior chamber reaction here to cause a hypopion. No steroids. So you know it's an infectious cause. You know, hey, this is different. I just need the antifungal, the antiviral, the antibiotic, and I'll get rid of the anterior chamber with that. There's no need for steroids. Cycloplegia is perfectly fine. So rule 1 is make sure there's not an infectious cause. You don't want to go down the wrong path of trying to treat it with steroids. And even a combination would not have been acceptable in any of those cases. Like, you know, I thought about that first small contact lens wearing patient with a tiny infiltrate of doing like a combo agent, tobramycin steroid or loteprednol steroid. But there were just too many infectious signs and symptoms. I mean, 11 out of 10 pain, 360 degrees of photophobia, mucopurulent discharge, drop of vision by 4 lines, you know, anterior chamber reaction. All those things point to an infection. So even a combo probably wouldn't have been terrible, but it would not have been the best thing to use. Pure antibiotic would have been better. So that's rule 1. If it's caused by an infection, put it in a different bucket. I mean, it is an anterior chamber reaction, but that's caused by the infection. That's all we're going to focus on. Rule number 2, check intraocular pressure. I think we kind of hit this one nicely in discussion with Joe and myself and Greg. And typically pressures go down due to inflammation of the ciliary body muscle. Can they go up? Well, they sure can. Trabeculitis, as Joe described, can be a cause of pressure elevation. I had a patient who had a bungee cord hit him in the eye. It might have been almost maybe 9 months ago. It's been a while. But he came in with pressures that were in the 60s. I knew it was above 60. I couldn't figure out the exact number. I'm amazed he didn't have a vascular occlusion with that kind of a pressure. But tons of fibrin in the anterior chamber. It just wasn't getting through wasn't getting out, and they're just getting buildup of pressure in the eye. So there are a number of reasons you can have pressure go up, but the number one group is, and we had that Zoster case earlier, that plasmoid looking eye with 56 pressures. But typically, if an IOP is going to go up, it's herpes simplex, herpes zoster, or it's Posner-Schlossman syndrome, all of which are in the herpetic eye disease family. So what a cool little hint for that detective work. When the pressures are elevated, which is not typical, they should be going down in the eye with anterior uveitis. You've narrowed it down to 3 potential causes in most cases, other than a few trauma examples.
And Paul, if you wanted to maybe throw in a potential fourth cause, a Fuchs heterochromic iritis. That's just not a steroid responsive type of uveitis, but it gets a modest pressure elevation, maybe into the 30s.
That's a great one. Love it. So there we have 4. And I love these inserts and ideas. It only adds to the educational value. So that's perfect. Thank you. Love it. All herpetic related in that group. Oh, look at that, Joe. IOP of 32 in this eye, 17 in the other. Sectoral iris atrophy. What do you think this patient has? Beautiful herpetic simplex example. So while you got to treat it obviously with your steroids pretty heavy, your cycloplegic, make sure you get an oral valcyclovir, an oral acyclovir, something to kind of get that viral cause controlled. And you'd be amazed at how much better your results are. Here's a person who's bounced around clinic to clinic. I'm getting these every 4 or 5 months. They never go away. And you add in the oral virals with the exact same treatment every other doctor did, and now it goes away. So it's one of the good things about, putting all this together. All right, I got another cool question here. Hey, Tim, I think you appreciate this. HSV, HCO presentations, where are you starting antivirals? At what point do you start steroids? Yeah, so obviously, any epithelial HSV, we don't have any steroids at all. That's HSV. But once it's just uveitic or just stromal or anything like that, or herpes zoster, which is just one big ball of inflammation, there's really not much active. I mean, there's some virus there, don't get me wrong, varicella, but that's one of the most inflamed eyes. You can start them both at the same time. Your steroids at the same time as your oral antivirals. The only time you wouldn't use steroids it was epithelial HSV, as we talked about, where you would wait, obviously, on any idea of a steroid. But for the ones we're talking about, the ones that are uveitic in nature without any epithelial involvement, you start them at the same time.
And Paul, let me add to that and if you're treating a herpes simplex, then, the next question does the epithelium have to be totally closed and so on and so forth? And I'll get yours and Joe's. I mean, this is my opinion. I mean, I'm not sure if it's a double-blinded study, out there, but when I start to see reversal that the dendrite is not spreading, it's starting to close. It could still stain. When I see reversal, I will add steroids, maybe at a lower dose and check them the next day. But to me, reversal is the key. But then when I add, it doesn't have to be 100% closed. But I'll take, your feedback and say, hey, Greg, nope, that's not how I do it. So
you can kind of sense the improvement you're seeing. I agree with you, Greg. You have a pretty good idea that, hey, I've been seeing steady, significant improvement before adding it. Like, for example, another example, not really what we're talking about too much now, like a patient who has a microbial keratitis, contact lens wear or not. The SCUD trials suggested that you might actually get less scarring, better vision a little bit if you start a steroid after the pathogen, after it's susceptible to the drug you're using, and after significant improvement. I think the last one's the key. So if I've got a significant improvement, like you're saying, almost closed, I'm a little more confident to go ahead and begin with the steroid. So I'm very similar to you on that one, but I have to feel like I'm seeing that kind of improvement. Tim's question also was good because he asked, what about the pseudodendrite? And thank goodness the name is pseudodendrite, because if it's a true dendrite, that's probably not a time you'll introduce steroids really ever, because it's HSV. But pseudo being additive, being elevated, being on the surface, not truly a breakdown, not a loss of tissue, you're okay to start it. So while you've got to, I'm glad you asked this, though, Tim, because if you look at rule number 1, it says rule out a keratouveitis. Well, herpes zoster is kind of a keratouveitis. And you know what? You're going to start steroids on that. But herpes simplex, microbial, bacterial, especially keratitis, fungal keratitis, those are the ones you got to be real careful with steroids.
And Paul, you mentioned earlier there was a fungal person, and you kind of mentioned it. And I think I want to get your opinion and Joe's opinion. Is that if I have someone with an acute red eye, 2 or 3 days, and I see some type of infiltrate, I don't really think fungal, because to me, fungal is slow to come on. And you said to that,
Yeah.
hey, that's been there for 10 days. Fungal is slow to come on, but then once it grabs a hold, man, is it a pain to get rid of?
100% right. It's one of the most difficult things to save the eye if it's gone too long. And these patients often don't come in right away because it's just kind of smoldering, like you said, or it's misdiagnosed, which can happen easily. A lot of times they do look like other stuff. I mean, you know, the incidence of a bacterial keratitis is going to be 9, 10 to 1, you know, so you're going to be thinking that's got to be it much more often. You have to have a strong history. Quite frankly, the majority of times when you actually do get an injury to the cornea from vegetative matter, it's going to be bacterial keratitis, not fungal, to the majority. But it does give you a hint that it is. So for all those reasons, you're 100% right. When it finally does show up and it's pretty advanced, it's really tough to keep that eye from perforating. If you catch it early on and you're able to make an early diagnosis, the prognosis is significantly better. But it's hard to make that early diagnosis because the patient doesn't always show up early like this one, or it's easily misdiagnosed. You're correct.
Yeah, I think Paul, the helpful in making the diagnosis or not making a misdiagnosis is you always have to ask, what else can it be? And if something is not responding really within 2 or 3 days to standard therapy, that's when we should be asking, I think, what else can it be? And let's not forget protozoan as well.
Yeah, that's true. Protozoan, Canthamoeba, you know, Mycobacterium. There's always these weird ones that kind of show up. Very good. We could do a lecture on that one time. Would be kind of fun too. Okay, rule 1 was rule out infectious Anterior Uveitis, not a inflammatory. That's, you know, that I'm glad you guys there was a lot of good comments in the chat area on that. Number 2, check pressures, good hint to what's going on. Also, you know, if you have a pressure of, you know, 50, you got to worry about vascular occlusion. You know, we always worry about the reason we call an acute angle closure an ocular emergency is because you can close off the arteries and the retina, the veins, central retinal vein occlusion, central retinal artery occlusion, because the pressure is so high. And that's why it's an ocular emergency. It's not because the patient's nauseated and can't see. That'll all get better. But 50 pressure, 60 pressure, that's when you lose vision permanently. But the point is, it doesn't matter if your pressure is 56 from acute angle closure or uveitic glaucoma or just significant inflammation like we have here. You still have that same risk. So if you go all the way back to one of the findings on herpes zoster, one of them was vascular occlusion, ischemic optic neuropathy, central retinal artery occlusion. I always wondered, why would that happen? Well, that's why it would happen. Your pressures can get way up there. Rule 3, rule out a previous ocular surgery. You probably know what I'm getting at there. If a patient walked into my office who had cataract surgery 2 weeks ago, and I look in the anterior chamber, now I've got like grade 4 cell and flare. What are you worried about? And drop in vision.
I think we have to always worry about endophthalmitis.
Exactly right. Now that's an anterior chamber reaction. You're worried about endophthalmitis. So in that case, that's the really key thing is endophthalmitis. In fact, surveys from older, you know, papers that I haven't seen any recently, but did show it takes about 9 to 10 days for colonization of the bacteria. I always used to think if you had a endophthalmitis after cataract surgery, it's going to show up on day 1, day 3. It actually doesn't. It takes like a week to 10 days to colonize to where it's significant enough to show up. So that's when you're really looking for it as a whole, 9.2 days on average. The point to this is I rule out ocular surgery and that applies to any. For example, if you have a penetrating keratoplasty, we do a lot of cornea. I still see a lot of patients who follow up with me for that. They're at risk of endophthalmitis until the last suture comes out, because the suture is a track into the eye for bacteria to get in. So until that point, they're stressed for it. I had a patient who came in who told me, oh yeah, I had a glaucoma surgery like 8 or 9 years ago, or maybe it was longer than that, maybe 10 or 12 years ago. and I'll look at the anterior chamber because they came in for photophobia and pain. They were sent to my clinic, and I've got like a hypopyon, grade 3+ cell flare. I'm like, what kind of glaucoma surgery did you have? Up under his upper eyelid, he had a bleb. Well, a person with a trabeculectomy is always at risk for endophthalmitis. It's a tract of fluid out, but unfortunately, it could also be a tract of bacteria in too. So while cataract surgery, you might only be at risk for that first 2-3 weeks. Usually, penetrating keratoplasty, you're at risk till the last suture comes out. Someone who's had a filtering bleb is at risk the rest of their life. So you got to look at any surgery because, as Joe said, the risk of an anterior chamber reaction that's significant when you've had a previous surgery is endophthalmitis. Now, of course, after 3 months, cataract surgery, after the last suture's out, penetrating keratoplasty, you're not at risk anymore, but you are for a certain amount of time. Gauge severity. Yeah, go ahead,
There's a
Joe.
question that came in.
Oh, good.
When you see a patient first time anterior uveitis has no corneal involvement or increased IOP, but lens pigmentation and probably early iris atrophy, you consider starting antivirals right away, or wait to see if the uveitis rebounds after treatment?
I'd start them right away. And I love this question. The reason why is that there's just not that many side effects to acyclovir or valcyclovir. It's not like I'm putting on something where, if you didn't need it, where you might have all kinds of issues. We could have resistance factors. I mean, you could get resistance in some immunocompromised patients and stuff. It's not very typical. So I feel no problem to give them 2 weeks. I have a hunch there's some atrophy. I'm not going to wait for the rebound. I'm going to use it right away because there's a good chance if that pressure is slightly elevated in that eye and you see iris atrophy, you've seen previous pigment on the lens, meaning they've had this before, it's at least a recurrence. I think that's the perfect patient to add in oral virals right away.
Yeah, I think, Paul, we're probably not prescribing enough oral antivirals in clinical practice. There are
Agreed.
so many things that can be herpetic. We just don't really think about it as much as maybe some ophthalmologists do. I know, at least in our in my system, my medical record for anterior uveitis, and when I go to the treatment, like my drop down list, one of the first things it says, due to the unilateral nature and the possibility of herpetic disease, I will add an antiviral. It's like an automatic drop down.
Hey, that's brilliant. And it should be. I love that. Yeah, I prescribe a lot. I think I prescribed 2 today. I had 52 patients today. So that's, 4%, not bad, but I do it a lot. And those are the ways you need to be thinking. So the doctor asked that question. That's exactly how you want to be thinking of this when you're managing these cases. It'll really set you apart from others, and you'll do well for the patient. And if it turns out they didn't have that, 2 weeks, 500 milligrams 3 times a day. While it's a little bit of work to remember it 3 times a day, there's probably no significant effects, issues, fairly benign pill relative to others.
Paul, let me just feed off of that before you hit gauge and severity, and we'll all kind of throw our 2 cents in here. And let me just kind of lower everyone's anxiety with, at least Valtrex or acyclovir, is that this medication is so cool in how it works. It's kind of like the Trojan horse, is that, as we know, we take a medication, it pretty much goes into every cell of the body, everywhere in the body, gets inside the cell. But this medication only gets activated in the cells that have the virus. So it goes in as a prodrug. The virus and the pharmacists and the guys and gals who made this medication, it goes into the cell. The cell, the herpes simplex or the herpes zoster produces an enzyme that cleaves off a part of this medication, which then activates it to kill the virus. So if it goes into a cell that doesn't have it, it just goes through the half-life and gets metabolized because there's mitochondria and all the stuff that's going on in the cell. But if the virus, because these viruses live in the cell, goes in there and the medication is there, it gets activated and it kills the virus. So long drawn out way to say what you and Joe said, these medications are really safe.
That is awesome, Greg. Brilliant. Love that. Great description. So let's gauge severity. That becomes important because I did a clinical pro, that must have been 15 years ago or 12 years ago. I used to put out these little pearls through review that would say it was like a 1 minute read, 2 minute read. And one time I put one out on when to know when you should order, serology or lab work in a patient who has uveitis, anterior uveitis. And it was just kind of basically said if you had recurrence, if you had bilateral, if you had hypopion, if you had an atypical presentation like significant synechia showing a lot of inflammation, KPs, that sort of thing. And keratotic precipitates are a wonderful insight into anterior uveitis. That's kind of a classic. And if it's mutton fat, it's going to definitely be a few unique ones, TB, VKH, and if it's not mutton fat, sarcoidosis is also mutton fat. It'll be more of the real small, fine keratotic precipitates. And so I wrote this, sent it out. I got a letter from the head of Scapin's uveitis, fairly famous uveitis specialist, actually considered one of the tops. And they don't always write the kindest letters. It was actually not a bad letter. But it was kind of like, Dr. Karpecki, just what, it was really kind of nice. I read your pearls, like your insights, that on and on and on. But in the second paragraph, he put down, I think you're misleading your profession. That's a real nice way of putting it. He said, you should really be ordering lab work on every patient. He showed a statistic of a paper that showed 56% of all presenting uveitis patients have are HLA-B27 positive, and you wouldn't know that unless you did lab work. So his point is fair. And if you're that top of the world kind of guy in uveitis, you probably do have to order it on everybody. But I think, and I look at that and say, you know what? Half the people aren't going to be positive for anything. So why put the healthcare system through that? I think you want to look for those that are more likely to be it and those that are atypical. Nevertheless, I ended up calling him. I didn't want to write a letter back. I called him, picked up the phone, talked to me for a while, and he ended up being a really nice guy. In fact, if he sees me at a meeting, he comes over and says hi. But that's the key. If you get a letter from somebody, never be antagonistic back. But at the same time, optometry needs to give themselves credit. We're at the same level. And if anything, we're probably even higher when it comes to anterior segment stuff because we deal more with it.
Hey, Paul, say that one more time. Say that one more time. We're probably even higher.
I think we're even higher in anterior segment. I went to a dry eye program. I know I'm getting off tangent here. That was put on by a group of ophthalmologists. They're pretty good. But honestly, they're probably a couple of years behind. And I'm not putting them down because, quite frankly, a lot of what they said were things I probably said from the podium 2 or 3 years ago myself. So it's just that we've evolved in knowledge and where we're at. And we're doing more medical. Here's my point to this, Greg. I've never met a surgeon, ophthalmologist, where I said, would you rather manage anterior segment disease, dry eye, anterior uveitis, or would you rather do surgery? Ever say anything but surgery? So we are in a position where we do. And if you sit through a 2-hour course like this, that takes you through 30 years of the top uveitis, and most of them being ophthalmologists. So being respectful, most are ophthalmologists that put insight into, or at least I observe them and put this together from that, working with them. Some are my own ideas too, though. You're going to be practicing at their level or higher. So it really is not being, diminishing anything, either group, but I think we're there. So anyways, so he, very respectful after that. We did get together to talk a few times and things on the phone. And I just love the fact that he's reading optometric publications. I thought that was pretty cool. Gauge severity to determine if further testing is required. Here's a good example. This gentleman came into my office very photophobic. I want you to watch this video and tell me if there, and look, I can barely keep his eye open. If there's anything there that says, oh, wow, this is a very significant uveitis, I better get a systemic workup because it's not the typical uveitis that shows up in my office. Okay. That's the great thing about taking a video. This guy was not going to let me look at his eye for long, so I could at least get a 20-second video. What'd you see?
I saw a little bit of iris sticking to the lens there, Paul.
I sure did.
I think I might have saw a little small hypopion, or whatever you want to call it, anterior cells at the bottom.
Look at that hypopion down there. Good pickup. I'm impressed. My residents I got some good residents right now, but over the years, I don't think they usually get all 3 of these. So that was really, look at all that synechia. It's probably about 300 degrees of synechia. And then those little brown things on the iris are keratotic precipitates there that you're seeing right at the very end. Let's see, we'll run it one more time. So yeah, when he looks up at the bottom, you see the white hypopion, a layering of white blood cells. You can definitely, which Greg pointed out, you can definitely see there it is really well. Then you see the synechia, 300 degrees of it all around. And then look at the cornea now. See all the little brown dots? It's actually not pigment. Those are chorotic precipitates. Some of them are a little lighter that are stuck to that. So we've got 3 things that are there. So my big indicators, already told you this: recurrence, bilaterality, synechia. If you got such a hot eye that the iris is sticking, like in this case to, posterior synechia sticking to the crystalline lens, or anterior synechia to the cornea, either way. You've got, KPs. I think you got to get a systemic workup. You don't need all of them. You just need one. Here's the interesting thing about this guy. I said, have you ever had this before? And he's like, no, I don't recall. So there's hypopyon. There's the synechia and the KPs right in that lower part here. This is his other eye. I said, I think you have had this before, because I don't recall ever being in this kind of pain. I said, well, your other eye's got some pigment there that indicated you might have had this at a young age. You might have had this. It wasn't as noticeable. I said, but you actually do have signs that it's bilateral and recurrent, not to him, but to you guys. Any sort of, pigment on the lens is an indication of previous anterior uveitis. So I think that warrants a ordering of systemic workup, KPs on the endothelium, hypopyon, bilateral presentation, recurrent presentation, non-responsive.
Yeah, I can't tell you how many post-ops I've done over the years, Paul, and whether they're cataract or cornea transplants. And, I've seen some pretty, inflamed eyes, but really from those, I've really never seen any posterior synechia. So when you see that, you've got something else going on.
Yeah, you really have to order it. That's exactly right. KP is another wonderful one to look at. Biggest indicator of anterior. Patients complaining about floaters, that's intermediate uveitis. That's your intermediate uveitis category. Your snow banking is intermediate. Those are all in that category. But KPs are classic for a significant AC anterior uveitis as a synechia, as Greg said. The idea of all cases, like Dr. Foster suggests, is not a bad idea if you're seeing a lot of secondary care things. There is a lot that could be HLA-V27 positive, but I really say this is the time to order it. And on my lab testing, there's some KPs on the endothelium there. You can see them off to the left of the beam. This is Kentucky. I practice in Kentucky. I see patients in Indiana as well. So this might not apply if you're in Florida or other areas, but in Kentucky, we have a really big horse industry and bourbon industry, and Eastern Kentucky, and we do see a fair amount of tuberculosis. I see about 3 cases a year on average. So if I have a patient with a cough, I'm not thinking sarcoidosis up here. I'm probably thinking of TB. So this may not apply to your lab testing you would have, but I think it's a nice initial guideline for what to look at. So I do a complete blood count with differential. I just want to make sure everything's functioning well from that side. I want to look at their lymphocytic count, white blood cells, basic metabolic panel, which is, of course, for diabetes and everything else related to that. I want to see overall inflammation with the erythrocyte sed rate or the sedimentation rate or sed rate. I want to do C-reactive protein, another good broad inflammatory marker. I like HLA-B27 as well. That's going to tell me everything from Reiter syndrome to juvenile rheumatoid or idiopathic juvenile arthritis to ankylosing spondylitis. You name it, they'll show up in an HLA-B. Crohn's disease is HLA-B27 positive. That patient I showed you with the hypopyon, the synechia, and the KPs turned out to be HLA-B27 positive, and he did have Crohn's disease. You're wondering, why would I do an RPR, FTABS? Well, a lot of my patients ask me that too. They're like, why is this checking for syphilis? Well, I'm amazed at, in fact, a non-responsive uveitis is typically syphilis in my experience. The ones I put them on steroids every hour and a steroid ointment at night, and they're not getting better. That's the first thing I'm thinking of is syphilis in that group. Quantiferin gold, that's for tuberculosis. And I'm amazed at how often Simplex and Zoster show up when I run a panel. Now, if you're lucky to see iris atrophy, as Joe pointed out very early on, well, then you're going to probably not need to run that. You've kind of got your answer. But sometimes it could be subtle too. That's there. So you're wondering, why don't you have an ACE like for sarcoidosis? I just don't see much of that. What about ANA? That's going to give you lupus and RA, well, I guess it could look at other things going on, but I feel like this gives me the majority. And I'm very selective. I mean, if I had an African-American patient come in with a cough, I may do an ACE with a chest x-ray. So sometimes you're going to be more specific based on the population that's more likely to have sarcoidosis. But this gets like 99% of everything I need every time, at least in Kentucky. So what does an HLA-B27 tell us? It indicates a systemic predisposition. We talked about idiopathic juvenile arthritis, rheumatoid arthritis, ankylosing spondylitis, Reiter syndromes, Crohn's disease, ulcerative colitis, and others will show up. But, if the history's, pointing to sarcoidosis, then I'll order an ACE. If it's TB, I'll order a chest x-ray, so cough to go with it. Lyme disease shows up in Kentucky, so I don't make it my usual, but if I have a patient who's still not responding and other weird things are going on, I'll do a Lyme disease serology. I may do an ANA, as I talked about, for lupus or JIA. If I start to see anything intermediate, floaters and snow banking to go with it, I might look for retinal issues and vasculitis. Sometimes I don't need to look past their hands and know what kind of systemic disease they have. So point is just kind of, put it all together as you're there. But it's good to have some guideline for testing. You can put your polling question up now, Greg. We've kind of covered a little bit, I think, of that one that we showed earlier.
Yeah, let me see if I can relaunch it here.
I may have messed it up on you.
Nope, I'm okay. I'm good. I'll relaunch it. I think most of the people. Let me just talk about HLA-B27 just real quick while this is running. I think people are going to answer it. Is that, human leukocytic antigen, every single one of our codes has HLA-A, HLA-B, HLA-C. And I forget, A, there's like 1 to 80. So you can have HLA-2, HLA-A2, and then HLA-B6. But then some people get B27 and you're going to have a C. Some people get dealt this B27 and then our immune system reacts to it. So in that one case where Paul had that, pain, if I have someone that comes in and they're 35 years old and they have a painful, super painful iritis, just that case that he showed on the video, the hypopyon, the synechiae, the creatic precipitates, and I was allowed to order one test, that would probably be it in a 35-year-old because they just have this immune reaction. So
I'm 100% agreement, Greg. If I could do one test, that's it.
There you go, my friend.
Nice risk group, sharp. Love it. Fantastic.
We know when you need the next one.
I will. All right, let's treat aggressively. This is key. I will get patients who they just never were hit hard enough by the steroid. Like, I'm gonna be blunt. You probably don't ever have a time you would start managing uveitis with, let's say, prednisolone, QID. You'd be Q2H. The only drug you get away with QID would be difluprednate because it's so potent. So that's one of my, it's funny because my residents, how they'll pass things on to the next resident coming in. They always pass this one along. They'll be like, don't ever treat a uveitis, Dr. Karpecki, QID. Well, you can if it's difluprednate. But you're right. I can't have any low dose attack. I see these patients who just never get better because no one hit them hard enough with steroids. We really have to be aggressive. Just like with antivirals, your discussion was great earlier. You really have to use it more often. Steroids have to be aggressive if you're using them. You've already ruled out an infectious cause. You've already ruled out endophthalmitis. You've already checked pressures and everything. Well, actually, pressures are usually lower if you have a trabeculitis with a steroid. So the point is you can be much more aggressive at this point. So it's Q2H or Q1H if it's pred, except difluprednate could be QID. I actually love putting them on a steroid at night. I always wondered, I started doing this this is one of my own pearls. I've never seen a uveitis specialist do this, but somewhere around 10 or 12 to 15 years ago, I started wondering, why am I treating a bacterial keratitis? I put them on an antibiotic at night. They actually have to wake up every 2 hours. And the second night, they can put an ointment in their eye, but I never go without some medication overnight. The corollary is an anterior uveitis that's extremely inflamed. So it's not like a mild case. This is the synechiae, the one Greg just described, that case, where I've got a highly inflamed eye. I thought, I don't want to go 6 or 8 hours without medication. I don't want the patient having to wake up and put a drop in either. So I've been using ointment. Like, I prefer lotiprandol because it's preservative free, but If it's expensive, you could use, Neosporin, dexamethasone, anything, Maxtrol, those sort of things too. I swear to you, I break more Synechia than I've ever done in my career when I started doing this. It just that controls the inflammation overnight. So using an ointment at night for your severe forms is really a good little thing to add in. Loteprednol is preservative-free, a little less chance of IOP rise, or a lot less chance of the IOP rise. So I would lean towards it, but if it's expensive, then just use whatever you can get as a whole. Difluprednate, another very unique medication that I think is the perfect uveitis medication. It's considered a very strong steroid in dermatology for this class of drug. It's difluorinated, which allows for double the increased potency. And also, if you look at the CH3 components to it, if you know your chemistry well, or you're really into this area, the organic chemistry, that's going to increase your penetration greatly and your overall anti-inflammatory effects. But the potencies on your fluorinated meds, they just increase a lot. It's a nice drop. You don't have to shake it, just like the loteprednol. Now, loteprednol, I don't mind the ointment at night. I probably wouldn't start someone on a loteprednol. And I know there's a study that showed the newer forms of loteprednol are equivalent to prednisolone. There was a study out of Japan. But if you looked at that study, they were looking at patients 7 days later. I think in the early few days, you really got to stick with difluprednate. You can get away with loteprednol ointment at night because you've already got the other things during the day in the severe cases. But I do like steroids you don't have to shake, like you like your difluprednates, like your loteprednols. BAK or sorbic acid preserved, fairly good size bottle. It's come down in price since it's been generic, so that has helped a lot too. This is a cool little study where they put difluprednate in bottle A and a placebo in bottle B. And in the other study arm, they put prednisolone in both bottles. So obviously the prednisolone would be every 2 hours and the difluprednate would only be QID. And then they looked at study results, and improvement in anterior chamber cell grade was non-inferior. So the statistically, actually numerically better in almost every category, but statistically the same, non-inferior. Anterior chamber cell was numerically better, but statistically the same. Symptom score, this one actually was statistically improved, which is interesting. Pain reduction was non-inferior, and photophobia from baseline was non-inferior. So the point of the study is, with half the dosing, this is at least as strong as prednisolone, dosed twice as much in every category that you look at. So
well, let me just add to your comment there, is that these are all ketones. The loteprednol is an esterase, and when you have a hot eye, you have a lot of plasma cholinesterase, and it just breaks it down. So it's great for ocular surface, but it's not great for uveitis. That's my 2 cents.
Perfect 2 cents. Couldn't agree more. It's just not a drug use. Mm-hmm.
I like that you're pointing out the difluprednate. Oh, by the way, if people don't realize, difluprednate, the Durezol, is now generic, so it's much more readily available for patients. I think maybe cash price maybe around $60 in my area. I think that's been very, very helpful. But people, you're pointing out the QID difluprednate versus every hour, every 2 hours of prednisolone. I think it's very important is don't treat the the Durezol the same as prednisolone, that if the inflammation is really bad, just use more and more and more of it. There was a nice paper that came out several years ago. It was in the optometric literature, and it looked at the steroid or the pressure spike in Durezol. It did a meta-analysis of previously published cases. Embarrassingly, one was one of my published cases, and they came to the conclusion that the pressure spike happened when people were overdosing the medicine. They were treating it like prednisolone, like every hour, every 2 hours, and they got the pressure spikes because they were overdosing it. So if you stick to 4 times a day with that, you really are going to reduce the risk of pressure spike.
Couldn't agree more. That's a brilliant pearl too. As the QID is going to get there, and you think, well, I'll just add more to it, then you just have more complications. That's awesome. So as Joe just said, if you're going to go the predacetate route, it's every 1 or 2 hours. If you're going to do difluprednate, it's QID. You don't need more than that. And that's a good starting point. But you'll notice there's no QID prednisolone acetate. My residents are like, well, Dr. Karpecki, what about a trace cell and flare, a grade 1 cell and flare? I'm like, Q2H. Once you got improvement, you're down to less than trace, then you can start your tapering. That's just the rules. I just seen too many where they just linger too long and it's harder to get them managed. No one hit them hard enough. No one was aggressive. So those are your two options. If you want to use lotiprandol, maybe at nighttime, not like Greg said, as the drop, not going to work well initially, really at all. You're not going to get the potency. Maybe way later on. You know, if I have a steroid responder, a glaucoma patient, I've got the uveitis really well controlled. It's like 2-3 weeks out, might consider it, but not in the early stages for the reason Greg said. And I didn't know that was the main reason. I just never felt like it was strong enough early on. But now I've got a understanding of why, thanks to Greg, why it's not strong enough early on. And so we're all in agreement on that one. Why cycloplegia? Well, I wish we had home atropine. It was one of my favorite cycloplegic agents ever. I actually induced a keratouveitis in my own eye by being stupid. I put some Karpecki in thinking that it would resolve some of the pain I had on a flight. I had like another 7 hours to get home. I happened to have a bottle of it. And my vision started crashing by putting 2 drops, just literally 2 drops. But I already had toxic uveitis. I think I got some sunscreen or something in my eyes. And anyways, I put a couple drops in thinking it would help with the pain so I could get home from a meeting, finish a meeting and then get home. And it was just not bright. It was early on in my career. So I ended up landing in Kansas City with like hand motion, I kid you not, and like 10 out of 10 pain. I couldn't see past here in that eye. And so I got off the plane. I called Joe Tauber, who's head of cornea, because I got off and I realized I couldn't see and I had this pain. I thought, I should check this. So I called Joe and he says, yeah, I'll see you in the clinic. It's 11 at night. I say, but I'll meet you over at the clinic. And he looked in there. He goes, man, it's one of the worst swollen eyes I've ever seen. He goes, I was thinking you either had an acute angle closure, but you're a myope. You had some infectious keratitis, but I don't see it. He goes, this looks like a toxic keratitis. And I had to break down and tell him what I did. And I tell that story for 2 reasons. Number one, when he put the cycloplegic agent in my eye, my pain went from 10 to 2 in about 15 minutes. It's wonderful pain. And the second reason I tell that story is that unfortunately, the guy who saw me the next day to see how I was doing was a guy named Jeff Gerson, who turns out to be a lecturer later on. And he tells this story, but not so flattering about me, when he had to actually treat me for a toxic keratitis I'd induced. But the point being, so I figure if I say it, I could be less, detrimental to myself. But point of cycloplegia is it does establish vascular permeability. It prevents synechiae by moving away, and it's magnificent. And I can tell you firsthand in pain management. Now, the most readily available cycloplegic agent on the market is the one you can't use, atropine. Atropine is too slow acting. It almost locks in a synechiae because it doesn't move quick enough. So I will tell you that's the one you have to avoid. I've only seen a few cases of synechia lock like this. All have been with atropine. I think what happened is now I don't say an across the board, but if it's an inflamed enough eye that there's the potential of synechia, atropine can lock it in because it doesn't move the eye out quicker. So if you're going to use it, you're probably going to start with tropicamide in the office, something like that. We already talked about iris atrophy, looking for other signs. And the reason I put that in as a treatment is there'll be times when you have to add in oral antivirals. There might be times when you have to add in other medications. So you want to just look for signs to when you have to do more than just steroids and cycloplegia. And then we covered this already. All right. Another very interesting drug is adrenocorticotropic hormone injections. I've been amazed by how this works for treatment-resistant uveitis and treatment-resistant keratitis. This is prescribed often by optometry. I think something like, based on the laws, as many as 38 states could prescribe this. You don't have to inject it. They have a home health nurse who teaches the patient. It's very simple, subcutaneous, right where you would normally do a diabetic injection here, intraperitoneal area. It's got a stopper on it, and you just put it in and inject it. Point to this is they train the patients how to do this. The analogy of adrenocorticotropic hormone injections, they're only twice a week for 4 months, is like if you had a neurotrophic keratitis, we have recombinant nerve growth factor today that you can prescribe 6 times a day for 2 months. And what you're doing is you're putting the nerve growth factor, the human nerve growth factor, back into the eye because the body's not making it. I have these patients who rebound all the time, who are not responsive to steroids, and they don't have, any sort of, not other things going on there. They have steroids responses, like their pressure's 38, and I'm trying to get their pressure low, and I don't have a lot of options other than a steroid. Where I have put them on this, and everything clears up because you're putting in the adrenocorticotropic and the pituitary peptides that I think their body's lacking. It's a wonderful tool to have as a last resort. There's not early cases where I would use this, but for what I call the 4 R's, resistant to treatment, rebounders, steroid responders, and reimbursement issues. They will cover it for patients who are below a certain income level. This is a good little tool to have in your back pocket. Not often used, but valuable in the background. There's actually a study showing when they used it for uveitis patients. These were pretty severe patients, by the way. If you look at the average, 56, actually more than that. Let's add 18, 20, 49, 27, 76% of these patients had 20/40 or worse vision. 20/70 or worse vision. So they were legally blind. So this was a pretty significant group of patients with advanced uveitis. And if you look at the results, 84% of them were significantly clinically improved based on the physician response. And 16% didn't move. And these were patients where nothing else would work. They could not control the uveitis. It had been up to 4 years in some patients. So it's a really cool last option. And it also showed that you could get 80% of your patients off steroids who had significant uveitis by putting them on adrenocorticotropic hormone injection. So I know that's a little secondary care, but I don't know. Optometry is kind of one of the big prescribers of this lately. So it's kind of in our wheelhouse, and it is a great tool to utilize when you can't find anything else. But you don't have to worry about injecting it yourself. All right, I think we got only 2 rules left to go through in the next 20 minutes, then we'll put up a few polling questions if we need to. Let's review the first 5. Do you remember rule number 1? Ruling out infectious keratitis. Rule 2, check pressures. It was a good hint, plus you don't have a vascular occlusion if the pressure is 55. Rule out previous surgeries. As Joe said, so you don't get endophthalmitis. Know when to order a systemic workup, recurrence, bilateral, hypopion, synechia, KPs, all that other good stuff. Treat aggressively. Difluprednate, QID, but not more than QID, to Joe's point. Definitely not loteprednol early on, to Greg's point, being, esterases. Difluprednate, QID, or prednisolone, 1Q1H or Q2H. That's your only options. Cycloplegic for pain. And I'm going to talk about how to treat, when to taper, and how to go beyond cell and flare, and then finally the last pearl about dilating. So here's a typical patient that I see, and kind of my rules of following. In a perfect world, and Joe's right, difluprednate in Kentucky is also about $60. That for some patients, that's great. It is the best drug in this class. For others, that's still too much. Then do your Pred Forte, just increase the dosing. Difluprednate, QID. So I got the perfect world. I'm going to start with that. I will continue that until I see significant improvement. And of course, my interns and residents always say, Dr. Perry, what do you mean by significant improvement? Well, I need to know that when I'm looking in that eye, there is no mistake that this patient is significantly better. They say that's still kind of vague. It's not vague. If you see enough eyes, you know when it's improved. You can tell. Is actually what Greg talked about, I think, earlier in one of those cases where you can see there's so much improvement, or might still be a little defect, but you know it's so improved that you could start a steroid there. And that's exactly what I'm talking about. You're going to go until you can tell this has gone from grade 3 cell and flare to a 2 or a 1+, something like that. So that's often about 2 to 3 weeks for most patients. So that gives you a time frame. At that point, I'll taper to 3 times a day for 1 or 2 weeks, depending on the severity of the condition. Like for shingles, probably for 2 weeks, then BID for 2 weeks, then QD for 2 weeks. And I know you're adding this up. You're saying, Dr. Brady, that's 2 months. I think that's one of the problems sometimes. We don't leave these patients on long enough. My average patient is going to be 7 to 8 weeks average. That means I've got 3 months and 4 months, and I've got a few that are done by 6 weeks. So it is a longer duration, I think, than most docs do. But I think it's also the reason I just don't see many rebounders. I don't see a lot coming back. I know when to add the valcyclovir. And then this last bullet, the third one down, might be one of the best pearls. So one of the uveitis specialists I worked for, I told you the story about it early, who called me over and said, how could you stop this steroid? And I'm like, there's no cell, there's no flare. I looked like 3 times in the eye. He said, you need to continue it for 3 to 5 days. And he didn't know the reason why. But there is a study, and actually someone sent me the paper like 10 years ago. So it was someone who was an instructor at one of the universities, kind of like, Joe was, or Greg. And so anyway, he sent it to me, and to this day, I got to go find it again. But it showed it took 5 days, 3 to 5 days for the blood aqueous barrier to restore after the last cell disappears. So although Dr. Godfrey, this uveitis specialist, didn't know the reason for it, he knew that if he left the patient on for 5 more days, once a day, after he no longer saw cell and flare, he had a lot less rebounds. And then the papers supported why. So that's kind of a good way to manage uveitis. Slow taper, but you're tapering once you have significant improvement. And you can alter it by a week or by 2 weeks. But when you're down to once a day and you don't see cell and flare, say, hey, I want you to continue this till the end of the week, 5 days later, once a day, and then you can stop. And then the last rule, and then we'll open it up for a little more discussion too. As we go through, do we need to do polling questions, Greg, or am I okay to just keep going through?
Yeah, go ahead, and maybe I'll throw some polling questions. We got some questions rolling into the chat box, but do your dilate, and we'll answer the questions in the chat box, and maybe throw some polling questions out.
I love it. It'll work out perfectly. So last rule is dilate. You don't think of this one because you're going to cycloplegia anyways, and the patient's going to come back the next day. But I do want you to dilate on day 1. It may take the patient an extra 10 or 15 minutes in the reception, the waiting area, but it's worth doing. 1, you can rule out other things going on. Retinal tears can sometimes have some cell, usually pigment, in the anterior chamber. Vitritis can spill over. Chorioretinitis with vitritis can spill over. And sometimes you'll see a systemic condition back there that helps you to know what's going on. Let me show you a couple examples. It's one of my patients a little ways back, but this patient did have cells, but pigment also in the anterior chamber. Let's look at the one on the right first. So today, today I have a confocal, and I love the imaging of that. But I also had one of these ultra wide fields, and it did a great job too. And I looked in the eye, and there's a complete retinal detachment. So sometimes looking in the back of the eye and what you think's a uveitis is not a bad idea. The patient on the left is a really interesting one. I was doing a retina workshop. So one of my first loves was actually retina. A few people know that because I'm mostly in cornea, but I've done retina preceptorships. I worked at a top 20 retina center for almost 4 years. But cornea is still my big thing. But I was doing a retina workshop. So that's kind of the extent of where I get to lecture on retina, is like doing workshops here and there. And then I was asking our colleagues, we're going to do this ultrasound. Do any of you have floaters in your eyes that you could, be the patient? And nobody put their hands up. It was only like about 11 doctors in this workshop anyways. And it wasn't just on ultrasound. It was like a whole on OCT. All the retina stuff was in there. We got to this station and no one puts their hands up. And I said, does anybody have I don't know, I had cataract surgery. We could look at the vitreous. Finally, one guy at the back says, my eye's acting really weird. He was a doctor from West Virginia. And he goes, I think I might have some floaters. I said, all right, great. Thank you for volunteering. Come up here. The technician starts doing the ultrasound and sees this kind of pattern. And this might've been a decade ago now. And the tech, it's funny because when the tech was doing this, you could see that he pulled his hand back, like, oh my gosh, what have I seen here? So Dr. Reggie, you take a look at this. So I go over there and I get the probe out. I'm doing my ultrasound on the eye. And I looked at the guy, I said, okay, step back for a second. I want you to cover up your other eye. I said, do you see any movement of my fingers down here? And he's like, I don't see anything down there. I said, you've got a retinal detachment. I called, I was in Nashville. Was I in Nashville at the time? I was. So I called, who's the great retina guy over at Steve Charles. Anyways, called him up. They did a pneumoplexy on this guy that same day and saved his vision. See, that's the value of going to CE programs like workshops. We actually saved the guy's retina in a workshop. But my point being, You just want to be looking at anything that could spill over that's in there. Not that you'd ever use an OCT for vitritis, but actually, I could actually see vitreous cell in this OCT I'd taken on a patient with uveitis. I wasn't expecting that. It's not a good use of OCT, by the way, but sometimes you can actually look in the back of the eye and see on the right cotton wool spots in a patient who had lupus, help make the diagnosis of the systemic cause. And let me tell you this story before we get to Q&A on the left. So one of the corny guys I worked with when I first moved, when I first moved to Lexington, I worked at Cincinnati Eye Institute, their Edgewood office, for about 5.5 years. There was a really good corny guy there who I'd known for a long time, Ed Holland, and we partnered up because that was kind of our passion for both of us. And it was a great 5 years because he saw some of the neatest cornea stuff ever, and I'd seen a lot for many years, so it just enhanced what we were doing. I did more of the ocular surface too as well. But anyways, but the next doctor I joined didn't have the 7 rules course. He didn't join a webinar like this, and he is a nice ophthalmologist, but, and I'm not putting him down, I don't sound like this guy putting down ophthalmologist, but he didn't have the 7 courses because he saw the patient on Monday, and I looked at the records. He didn't dilate, and no fault at that. I probably didn't even have this course together then. And most people don't dilate. He didn't check IOP, which probably wouldn't have mattered. He put the patient on Pred Forte QID. Well, that should have been difluprednate QID or Pred 1 or 2 hours. He didn't cycloplegia. I actually had to dilate this guy when he came back. What else? I guess he ruled out Anterior Uveitis because there was no corneal involvement. He had no IOP measurement, so he didn't have a lot, and that's okay. I don't say that to be mean. I don't think people have courses like this that break everything down into 7 steps. But the point is, Wednesday, 2 days later, I get one of those days where it's 11 in the morning and I've had 10 work-ins. I might get 1 or 2 work-ins in a day, maybe 3 in a busy day. Never had 10. And one of the front reception lady comes over and says, kind of looking down sheepishly, Dr. Karpecki, I've got another emergency. And I said, okay, what's the chief complaint? Because it better be good, I'm thinking in my mind, or I'm not going to have time to see an 11th work-in. We're already an hour and a half to 2 hours behind. I said, well, let me ask give me the chief complaint and we'll see. And she comes over and he says he thinks he's going to die. That was the chief complaint. I thought, we probably need to check that one. So he comes in about an hour later. There's a person helping him in. He was seen on Monday, and we just described that. He's got his hand over, he can barely move. He's in extreme pain, but not just eye pain. Like he can't really hardly move. He sits down, he's in pain. He's almost groaning. So I look in, I dilate him, and I look in the back of his eye, and I see vasculitis. I see these headlights in the fog. I can't remember if that was his eye. It was something similar to that. It was a mess. And so I get his history. I find out he's homeless. He was addicted to drugs, lost his family, his good job, his good family, his life. And I tell you this story because it's a great kind of ending to the webinar. It's a true story, of course. And I call Kitchens, who's the head of retina at the time, or he's one of the retina guys above me. I said, John, I got this patient. Is probably your world. He presented with an anterior uveitis. Wasn't dilated on day 1. I didn't tell Kitchens this, but he wasn't dilated on day 1. So no one knew this was actually spillover in his anterior chamber. I said, he's really got more of a chorioretinitis, probably vasculitis issues, thinking ANCA, whatever. Turns out he doesn't have funds, and he was homeless. He didn't have a lot of money. And he didn't look homeless, to be honest. He had a nice shirt, pants, nothing fancy, but I guess you shouldn't stereotype. But nevertheless, I said, I don't know what to order. Because what should we order for him? I could get a place that'll do some lab work. They're not going to do a full panel, but if we could do 1 or 2 tests, I'm sure they'll do it for free through St. Luke's, which is a hospital nearby. So, well, if I had to guess, I would do an FTA-BS. I would rule out syphilis. And he said, all right, I'm with you. Let's do that. Came out positive. Here's the interesting thing about this story. He had, yes, positive for syphilis, but it was syphilis encephalitis. If you look up that condition, it's around the brain now, you have about 48 hours to live. So this guy saying he thought he was going to die was legitimate. He truly wouldn't have been around 2 days later. And one of the coolest things, we got a letter from him like 4 weeks, 5 weeks later. He said, I want to thank, the doctor I saw the second time, put that in there, at the clinic I was at, not to name any of the other doctors there. he said, I want to tell you, I'm trying to get my life back in order. You guys saved my life. The doctor, had told me I should definitely send a note. Just want to tell you how grateful I am. We kept this on the board for years. I was there for about 5 years. I think I was like in my second year I was there. So for 3 years, I wish when I left the practice, I had taken that note. I just forgot all about it. But point to this is, it wasn't like we did anything great. We just knew the 7 habits. We knew, here's what you got to do to protect you and to protect the patient. And now all of you who've spent all this time with us tonight have the 7 habits. And while you probably knew all of them, probably had knowledge of most, now you got them in kind of a nice order. So the next time you see a uveitis patient, anterior uveitis, you probably will really do well.
Hey, Paul, can you do me a favor? Go back one slide, and that slide that's on the right there, if you can just send that to me, I'd definitely put your name and put courtesy to Dr. Paul Karpecki. But that
Sure.
one on that slide right there, that on the right that has the one cotton wool spot. Joe has heard me say this numerous times. We all have these wide field imaging, depending on what company you have, and we find hemorrhages all the time. And do I work them all up? Probably not. But that's a cotton wool spot there on the right. And a cotton wool spot is a sign of infarction. That's not healthy. Do I work every cotton wool spot up? Yes. Now, is that diabetes or hypertension? Absolutely not, because I don't see any hypertensive retinopathy. I don't see diabetic retinopathy. There's leukemia, anemia, B12. There's something going on. That patient needs worked up right there. So that's my parole on that picture.
I'd be
And you
honored.
could send it to me. I'd love to use that.
You
Give
got
you courtesy of Paul Karpecki.
it. Go ahead too. I might even have others I'll send you. Be glad to do it.
Joe, do you want to
right.
handle the questions for Paul as he goes through the conclusions here? Paul, why don't you do your conclusions, and then I'll run some polling questions and Joe will handle the questions.
Yeah, I think anterior uveitis is one of the most common conditions out there. This group looked to be pretty advanced when they filled out the survey, and that's just a testament to how common this is. Follow the 7 rules. It's going to keep you protected. It's going to protect the patient. You're going to have really good success with it. It's been flushed out over almost 3 decades, and not just my knowledge. These are some of the top uveitis people I've been lucky to work with, and I took some of their ideas and others, and even listening to top people like Joe Gregg and other colleagues. It's all in there. Understand the importance of systemic disease also in these cases where you could have other things going on, and when to do the workups. And thanks for being part of this. Thanks for participating. Thanks for listening to a course on anterior uveitis. Not the one that usually would be the most popular, but I think it's a great area of ocular disease management for our profession. So yeah, let's do questions.
All right, Paul, question is, what about atropine for posterior syndicate that is older or chronic?
I think at that point you're fine. I really think that when it's the time that I'm worried about atropine is when I have a hot, sticky eye. I've got to move that iris away. It's inflamed. If it touches anything, it stays. And atropine is so slow acting that it practically pushes it. Doesn't really push it, but it just doesn't let it move away, so that it forces it to have a better chance of sticking. So in a late, done, treated, no issue whatsoever. The only time you got to worry about lock is like when you're in the heat of inflammation of uveitis, when there's a chance of synechia attaching.
And Paul,
So
is ACTH...
one of the things that, hold on,
Sorry.
Joe. One of the things that I do whenever I like atropine in the practice, but I do cycloplegium in the office, either with tropicamide or cyclopentolate, because we have that in the office. It's a little quicker acting. And then I get them on with the atropine. So, but Paul, there's your answer to that question here, polling question.
This group is good. I'm impressed.
All right. Joe, go ahead. Sorry.
ACTH available in Canada, and how do you order the injections?
Yeah, I think it is. So you have to go to the company's called Mallinckrodt. They are a company that has had this. Is actually a drug that's been around a long time, but it affects all the melanocortin receptors, including MC2R, which is, of course, the adrenal cortex. The only place in the entire body where all 5 receptors are involved is in the eye. So they've really started targeting eye care practitioners. I think there's plans to be in Canada if it isn't already there. But I'll have to look into that. I'll have to look into it. It is in all 50 states. Optometry can prescribe it in 38. I don't know the 12 it can't. And even then, it's kind of vague because we're not doing the injection. Although 32 states we could do the injection, we're not doing it. So it's not really an issue, but there still are some states where it's very, very gray. But most states, it's not an issue. And Canada, I'll have to find out.
Paul, what is your typical follow-up schedule during the tapering process?
Yeah, I like that question. And I think the longer you practice in certain areas like uveitis, the more you stretch it out. So don't use this as a guideline. Like when I first started seeing uveitis patients, I would see them the next day, day 4, day 7. Today, I might do a day 4 only, unless it was like this really bad case or I'm worried about synechiae or something like that. And then I would maybe see them the next day. But typically, it's first treatment. Let's see you back in around day 4. If pressures are fine, everything's normal. Let me see it about 10 to 14 days. Let me see you at 2 weeks from there, which is like your 1 month. And I'm just monitoring it over that time. Of course, more severe, a little more frequent follow-up. If there's hypopion, high pressure, something atypical, potential synechiae, I'm going to see them much more often. But that's pretty much it. And really, once they get to where I feel like there's significant improvement, like let's say they're 4 to 6 weeks out, sometimes, and usually significant improvements about 3 weeks. So 3 to 4 weeks, and I'm going down to 3 times a day, or sometimes even 2. Then I'll see them about every 10 days to 2 weeks.
Mm-hmm. Yeah, I think the important thing, as you mentioned, with experience, and I agree, Paul. If you've got a significant pressure elevation or a lot of inflammation, I'll usually see them within about 48 hours, maybe 72 hours. When there's a lot of initial inflammation. But what I want to stress to everybody out there, daily follow-up of uveitis is like watching paint dry. There's 1,000 cells in the chamber on day 1. Next day, there's 998 cells. It's boring.
Right on.
And what is your pred forte taper schedule, Paul?
So it's not too dissimilar. While I was, let's say, Q2H at the beginning, when I see significant improvement, I'll drop to QID. And after maybe a week, 2 weeks out, I might go to BID, then QD. Now, I do stay on QD at least until the last cell's gone, and then 5 days afterwards, they stay on it.
And how do you narrow down?
And I would add to that, to the point where, again, experience, sometimes it's QID for a month, BID for a month, 2 to 3, 4 weeks. It's a 3 to 4 month treatment here in some cases.
How do you narrow down your labs to order, Paul?
Really narrow. How do I narrow it down to that selection?
No, the labs that you order.
So I actually have it all on one form. So those ones that I showed you, the CBC with differential basic protein panel, ESRC reactive, FTABS, PRP, my HLA-B27, my quantiferin gold, and my zoster versus HSV1 or 2 are on a form. And I just check the boxes I need, which is kind of all of them usually, and send it off to the lab. That's all. And sign it. So you might tweak it for where you live. If you're in a high Lyme territory, you might put that in. If you see a lot of sarcoidosis, you might have an ACE in there. But for the most part, in Kentucky, that panel I gave you is going to be very consistent over almost 20 years or 17 years now of really refining it to the most common positive diagnoses that show up with uveitis.
Paul, I'm gonna take a different approach that I do, in that I don't order testing for uveitis. I'm in a big practice that has a big reputation, and we work a lot with other specialties. I'm going to make the diagnosis, but I'm going to share it with the rheumatologist, because they kind of have the skill to pick certain things up that I don't, and they're the ones who are going to be treating these patients. So I will work with, I work with a lot of I work with neurosurgeons, neurologists, primary care physicians, and these are outside physicians we that we work with in our area. But I have a good relationship with rheumatology, and I'm gonna send them and tell them what I found ocularly. And just as they have patients that have eye problems, they send them over. So I like to work collaboratively myself.
Correct.
Hey, Paul, go ahead and stop sharing your screen there. And
Oh, yeah, definitely. So we already
no
did this.
worries, no worries, nope. And
Okay. Should be
I got
stopped.
one more to share here, and see if I can figure out where that is.
And Paul, there's a question. What's your best class to control the steroid responders?
Oh, I love this. These questions have been great, and responses to the panel polls have been really good too. This is really important because prostaglandin analogs are not a good steroid to use in uveitis. You add to the inflammation. There's some debate if carbonic anhydrase inhibitors are ideal too. They can slow down the endothelial pump function. They're okay. I typically like 3. I like beta blocker as a whole. I don't mind brimonidine, to work as well in that group. And if I have to go, systemically, I could do, non-sequel zolamide or something like that to Diamox to kind of pull some fluid peripherally out in this group too. So I tend to still keep a bottle of that in my shelves. 250 milligrams non-sequels. I give them 2. Will combine with beta blocker and brimonidine. I see those don't seem to cause a lot of inflammation. They seem to get the pressure down. But ultimately, it's the steroid when you have a trabeculitis that lowers the pressure. So get them started on steroids with those drops, and that's your most likely ability to get the pressure down.
Joe's heard me make this comment, a few times, is that, on a unilateral steroid response, I'll go to Combigan. And a lot of times I'll use Combigan QID in the right eye. People will look at me and go, oh my gosh, you're using it QID and it's supposed to be BID and you got beta blocker in there. And I say, well, what happens if I use this BIDOU? Am I exposing this patient to 4 drops in both eyes all day long? So I have no problem going with QID to Combigan. I'm a little cautious again, Paul, like you said, with the carbonic anhydrase. It can affect those endothelial cells, maybe get some cornea swelling, but sometimes insurance dictates I go that way. But those beta blocker drops, I don't mind using QID in one eye because they're still getting 4 drops exposed to the body. So don't be afraid to use that out there, guys and gals, 4 times a day.
Love it. Actually, that's my preference too, is Combigan, but I never thought of QID. I like that.
Any other questions, Joe?
That's it.
Paul, this certainly was not rehearsed out there to the audience, and they've heard a lot of lectures, and, we all danced great together. And I think that just goes to show the expertise and trust that we have for each other. I think this was one of the funnest that I've given, just for the fact that we had a conversation tonight rather than you just reading a bunch of slides out here. So I want to personally thank you out for doing this. And Joe, I'll let you make a comment, and then Paul, please wrap up.
Yeah, I think this was more a conversation between friends. Hopefully we didn't derail you too much or step on your material, but maybe next time, maybe early next year, we should do a conversation with just a topic.
I love it.
And not really have the conversations in cornea, and just we all talk and take questions.
I think it's brilliant. I love that. I thought it was excellent. I think it added a lot. Your comments were insightful. They were beneficial. It's the best way to learn is to have different people adding in their key insights and pearls. There was, definitely no stepping on toes. It was fantastic. It made the presentation better, probably much more interesting because you hear different voices and different insights. And I think it enhanced it. So thank you. It was a wonderful opportunity to join the 2 of you. I appreciate the invitation, and obviously a really good group of doctors here tonight based on their questions and their responses.
And Paul, before you leave, if you want to take a look at the chat room, you're getting your congratulations and your round of applause.
Thank you. Thank you. Happy Thanksgiving. All of you have a wonderful next week, and hard to believe it's Thanksgiving in a couple of weeks.
We appreciate you, Paul.
Thank
Thanks
you.
for all you do for
Right.
optometry.